to this computer. And then also going to record here. Okay. Okay. Welcome, everyone. Thank you for attending today's Gutsy Learning Series. We'll be starting shortly at 7 on the dot, so in a minute. Okay, so again, welcome everyone. Thank you for being here today. Today, our webinar will be on managing your mental health and IBD. So my name is Roshane, and I am the Manager of Research Grants, Impact Communication, and Evaluation at Crohn's and Colitis Canada, and I will be the moderator for tonight's event. Before we kick off, I wanted to go over some technical details. So this webinar will be offered with live translation in French. For you to access the French interpretation, in the bottom of your screen, there should be a globe icon and under it labeled as interpretation. If you click interpretation and then French, you will hear the French audio. If you want to see the French slides, when you right above your screen where you see my face, there'll be a views option. And when you click view option, choose French, and then you will be CCC French, and then you'll see the French slides to accompany the French audio. If you experience any technical issues, please try refreshing the website browser, but you can also submit your questions in the Q&A box, and we will try to get to you as quickly as we can. Next, Next, I wanted to acknowledge the rich history and heritage of Canada's Indigenous people. While we meet today on a virtual platform, we recognize the importance of the lands which we call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Through this acknowledgement, we convey our respect for the traditional territories of the Indigenous communities and contribute to the promotion of reconciliation. Next, I'd also like to issue a quick disclaimer. So the content in this presentation by Crohn's and Colitis Canada is solely for educational purposes. While the information holds general value, it may not be applicable for specific medical situations. Online resources should not be seen as a substitute for personalized judgment and care, which is provided by a trained healthcare professional. Lastly, Crohn's and Colitis Canada does not endorse any external product or service mentioned during this webinar. Lastly, this presentation includes discussion of suicidal thoughts and related mental health topics, which may be sensitive for some participants. So please be aware of that during this webinar. For those of you joining us for the first time, I wanted to share Crohn's and Colitis Canada's commitment with you. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic diseases. Next, some quick housekeeping. So CCC has launched an unmet needs survey, which asks everyone in our community to share their experiences, concerns, and challenges when living with IBD or being affected by IBD. So you could be a patient or a caregiver. So this information is critical for CCC to develop programs and to also ensure that your voice is heard in every step of the way. Next, CCC also has an online platform called Crohn's and Colitis Connect, which is essentially an online community only for those living with IBD, where they can share the challenges of living with these diseases. And it's supposed to be a safe space for you to seek advice and understanding. So we really encourage everyone attending these webinars, if you feel like you want a community, to please join CC's Connect. Other things that I wanted to share that's also taking place at Crohn's and Colitis Canada, we have 2 peer support events in English coming up this year on December 2nd and December 3rd. You can find more information about this on our website and under the events page. And lastly, I wanted to share that our next webinar will be our last webinar for 2025. And this is a really exciting topic. It's new and emerging IBD therapies in Canada. We have our lived experience partner, Sophie, who will be sharing her experiences of cycling through different treatments. And then this will be supported by Dr. Robert Batat, who is a gastroenterologist in Montreal, and he'll be sharing all the new information about new and emerging therapies in Canada. So please sign up for that as we wrap up the year. Okay, so before we begin the session, we usually launch a poll asking our attendees to share how much they know about this specific topic. So I'll be sharing that right now. And I'll keep it on for about 30 seconds. If everyone can take their time and share how they would rate their current understanding of these topics. Okay, I'll wrap it up. Cool. And I'll quickly share the results. So it seems that about 25% of folks rated it about 5 out of 10. And so there's a range, but most of it the average seems to be around 4 to 5. So thank you for taking part in our poll. Sharing. Okay. Okay. So next, I'm extremely excited to start off our webinar by introducing our lived experience partner, Arielle Thompson. Just briefly about Arielle, she is a mental health advocate who is completing her master's in social work. She draws from both her personal and professional expertise to speak about the complex interaction between IBD and mental health. Her experiences have led her to adopt a compassionate, trauma-informed approach to managing mental health, and she openly discusses about pain and grief as emotional realities of IBD. So Arielle, thank you again for being here with us tonight. We're very excited for you to share your experience with us, and please take it away.
Thank you for having me. So I was so honored to be asked to share my story, and I'm very excited to be here with you all this evening to discuss this very important topic. As I share my story with you all, while you will hear parts of your own story in the pieces that I share, keep in mind that my disease journey will look very different from yours, and specifically, I will talk a lot about the bi-directional relationship between stress and flare-ups, which may be very different for you, as everyone's journey in life with IBD and mental health is uniquely individualized and deserves support tailored to their specific needs. I also just want to put out a disclaimer that I will be sharing my raw and unfiltered journey of IBD and my mental health journey with you. This will include discussing experiences that were traumatic in nature. So if any difficult emotions come up for you, please feel free to take a break, do what you need to do in order to care for yourself, and you can return whenever you feel ready for that. To start at the beginning, my journey began when I was 11 or 12 years old, which is when I started experiencing symptoms, which involved abdominal pain and passing blood. As a young child, I became so used to seeing blood and experiencing pain that I didn't conceptualize that it was not normal, and therefore I didn't think to tell my parents. I eventually mentioned it randomly in a conversation when I was 14, and that is when I saw a doctor who first misdiagnosed me as having hemorrhoids. From there, I was able to get referred to a gastroenterologist, and then I was recommended to have an endoscopy. So when I went to have this endoscopy, I was given the choice of having sedation provided through a mask or an IV. I chose a mask thinking, great, I won't have to have a needle. Turns out you still need an IV regardless. So when I went into the procedure room, my parents had to stay behind, of course, and I'm in this medical room for the first time, surrounded by all these nurses who, as a little child, they just seemed so big and tall and in all this medical gear. I began to feel very overwhelmed. They started to put the mask over my face, and this was suddenly very scary for me. I proceeded to ask them to stop, that I didn't want to do it, and to wait. And while I was attempting to get the mask off of my face, several nurses began to hold down my arms and legs so I could not fight them. And of course, I was then forced to be sedated and go through with the scope. I woke up having my first ever panic attack. And if you've had a panic attack, you know it feels like it lasts hours. Thankfully, my parents were there to come and support me and were incredibly upset at what happened and ended up talking to the staff there. I was officially diagnosed with indeterminate colitis. My disease began to progress, and I began to experience flare ups, each one lasting longer than the previous. My GI doctor had told us that my disease was mild. While some people can have surgery, that would never happen to me. Mine wasn't severe. Throughout elementary school, staying up all night at sleepovers as young kids do, this influenced me to have flare ups. And in high school, it was the stress of exams. And in university, it would, again, the stress of exams, or if I experienced a relationship breakdown, it would impact flare ups. I could actually begin to predict my flare ups. Within a week or two of a stressful event, the bleeding and abdominal pain would return like clockwork. As a child growing up with chronic pain, where pain management was never something that was ever discussed, to me, pain became such a normalized part of my life that I learned to accept this is just how my life is now. The only way my young self could make sense of why this had happened to me was I began to think, I'm in pain because I did something wrong. It's our human nature that whenever something bad happens, we analyze what went wrong so we can prevent it from happening again. We attempt to gain control. This led to continuous overthinking and analyze if I did anything wrong each time a flare up occurred. Did I eat something bad? Was I not behaving well? Did I make a mistake? I started blaming myself for flare ups, which resulted in a toxic relationship towards my body as I began to hate my body, as it felt like it failed me, only bringing me pain. I began to suffer with anxiety and depression, as when avoidance is overutilized as a long-term strategy, the pain and distress does not disappear. And for me, it just manifested in a different way. I didn't tell anyone when I was experiencing pain. The only way I was able to cope with what was happening to me was to push through, not think about it, and distract myself, usually with watching TV and movies. This was the only way I knew how to survive at that time. And that coping strategy is avoidance. Because I never faced my emotions, I never learned how to express my emotions or develop the skill of emotional regulation. Whenever I was asked how I was doing, I would say I'm fine, even though I was far from that. And that wasn't to intentionally hide my suffering, but because I actually did not know how to talk about my feelings. And I didn't actually have the awareness to recognize I was not fine. For myself, it wasn't so much the physical pain that was challenging. Like, of course, being in pain was awful, but I had become so used to that. It was the emotional distress of the pain that was way more agonizing for me, never knowing when it was going to end. After years of suppressing my stress and emotions through avoidance, my colitis progressed significantly. And in the second year of university, when I was 21 years old, I was hospitalized with my CRP, which is C-reactive protein. For those that don't know, it's a marker in your blood that measures inflammation in the body. And mine was over 700, which is significantly high. I was given emergency surgery as my risk for bowel perforation was very high. I had my entire large intestine removed and was given an ileostomy. And this is when an opening called a stoma is created in your abdomen to allow waste to leave the body through what's called an ostomy bag. I was told by my surgeon that many people are cured after this surgery and I would go on to live a normal life. This was unfortunately not the case for me. Within the next 3 years, my life would be turned upside down. I had to drop out of university as I would spend the next 3 years, the majority of this time hospitalized. I had an additional 5 surgeries. I developed a hernia from a surprise hole in my stomach. I had a bowel obstruction as my stoma actually narrowed and it had to be surgically reconstructed. And then I started developing these chronic bowel obstructions that were so problematic as each surgery I had, I would get a bowel obstruction no matter what. And they lasted from 2 to 6 months. It became very clear that having an ostomy was actually making me very sick and I needed to get rid of it. I had an ileal pouch anal anastomosis or J pouch surgery, more commonly known. And this is where your small intestine is used to create what's called a J pouch to store waste. And then I had another surgery where that was actually reconnected to my rectum. After the surgery, I experienced another bowel obstruction. And during this time, a surgery fellow was pushing me to eat, thinking if you just eat, your body will adjust and things will be passing again. I knew from my bowel obstructions that it's dangerous to eat when you're obstructed. But despite her pushing, I finally agreed to listen and my bowel perforated. I started having an extremely high fever, could barely keep my eyes open, and then developed tension pneumoperitoneum, which is a severe complication when large amounts of air from the bowel perforation build up in the abdomen and then travel to surrounding areas, which for me was my left arm. It was without a doubt one of the most painful complications I ever experienced. This also occurred on a Sunday evening. And if you know hospitals, all the surgeons are home at night and you have surgical residents running the hospital. So despite me having a CT confirming my perforation, there was no surgeon in the hospital to do my surgery. I had a significant high risk of getting sepsis, but I had to wait several hours until the next day when my surgeon arrived. Months later, I am discharged and home, and the reality of what has happened to me for 3 years hit me like a brick. Being in the hospital in so much pain, I had been on strong pain medication for 3 years that I never processed what had happened to me and the trauma, both physically and emotionally. I remember being told by nurses that I'll never be able to return to school and that I'm too sick to become a social worker, which was my dream, or maintain a job. I had gastroenterologists and surgeons constantly telling me that my colitis was one of the most severe and complex they had ever seen. After my JPEG surgery, the bowel obstructions reduced, but they were still consistent in my life. Every few months, when there was a stressful event with work, school, or a relationship breakdown, I would get a bowel obstruction. While it did not make any sense to the doctors, it became so clear to me my inability to cope with stress and process difficult experiences and emotions was literally causing me to have bowel obstructions. I also developed fistulizing disease, which is a tunnel that forms between the intestine and another part of the body, which causes pain and can develop infections. And this is when my diagnosis was actually changed to Crohn's disease. I realized I was not going to make it if I did not do something different. I began to work with a trauma therapist and really began to unpack my illness, my childhood, and how I had conceptualized the pain and trauma I endured. I learned how to grieve, and I did not know how desperately I needed to grieve as part of my own healing journey. Grief is not just about death, but it is the natural, emotional, and physical response to significant loss. And I had experienced a lot of loss. I had to grieve the life I had envisioned for myself, which was very different than my life had happened to be, as well as the plan I had for my life was completely uprooted. It ended up taking me 10 years to graduate university. And a year later, I was accepted into my master's in social work. But in those years, I really began to heal. I did eye movement desensitization and reprocessing, which is a type of therapy that processes trauma and difficult memories. And I was able to look myself in the eye and offer self compassion for the first time ever. This shifted my perspective from blaming myself for getting sick and holding fear based beliefs about being scared of food and the pain and that my body had failed me to acknowledge it, to acknowledging that this terrible thing has happened to me, but my body has overcome a lot and is resilient, and I get to nourish it and care for it because my body is my home. And feeling safe in my body allows me to be connected with it and experience whole body peace. I also developed the courage to bring people in this journey with me. I realized that I didn't have to navigate this disease on my own. This also fostered accountability for myself so I don't fall back into that pattern of avoidance. I also journal every day. This actually forces me to get the emotions out of my body and brings emotional and physical relief by connecting my mind to my body. The difference between feeling equipped to manage challenges of IBD versus having to be reactive, as these same challenges may put you in a crisis, is so impactful. There is so much empowerment in knowing what you need and how to support yourself when you're up against an IBD challenge. While there's so much about IBD that we cannot control, we can choose how to care for ourselves, which can increase our tolerance and resilience. Thank you.
Um, Thanks, Arielle. Thank you so much for sharing your story. I don't imagine that was easy, but it sounds like you've really processed and you're trying to, put everything into context. And again, I'm sure this resonated with a lot of individuals. And if there's someone going through something you went through maybe earlier on in your journey, that this would help them kind of envision a future that is, more optimistic and manageable. So thank you so much. I really appreciate you sharing your story with us. Okay. Um, so next, we will move on to our main part of our talk, which is the talk by Dr. Tripp. Quickly, I'm just going to briefly introduce Dr. Tripp. So Dr. Tripp is a professor of psychology, anesthesiology, and urology at Queen's University. He's also chair of the Queen's Health Science Research Ethics Board. He also has coached Olympic and professional athletes, including members of the Ottawa Senators hockey team, on mental performance and resilience. His research focuses on understanding how mental health and physical pain are connected, and he has published over 100 scientific papers. Lastly, Dr. Tripp has also received multiple teaching awards, which highlights his dedication to mentoring and education, also at Queen's University. So we're extremely lucky to have and fortunate to have Dr. Tripp with us here today to share about his research. Please take it away, Dr. Tripp.
Thank you. I appreciate it. Can you hear me okay?
Yeah, you sound really good.
Okay, great. Thank you. Now we'll just get the slides up and we'll be rolling because I can only see my little tiny head on the slides at the moment. And we don't want to see that. But let me start by, until we get this technical stuff figured out here, let me just start by saying thank you. And Arielle, thank you for sharing your story. That's brave and important. And I think it is it is a testament to the place that you're at now and the place that you're headed, that you're able to kind of contribute to the understanding of this disease in such a passionate way, but also in, as you mentioned, a raw way. And I think that the management of chronic illness is not pretty. It's tough, and there are peaks and valleys, 100%. And sometimes the valleys seem long. But as you've shown, the ability to kind of bounce back is really important, and the ability and how you did it is really important. And what's interesting is you're going to be a part of several things that I'm going to talk about when I get to review the research that I think is important for us to hear and see tonight. And that's going to be an important part of kind of how I wanted this to go tonight. I mean, thank you, CCC, for inviting me. And one of the things that I was saying off camera earlier was that, I've been in a lucky position for a whole bunch of years to work with some really bright people doing some really cool things. And I've been away from patients and I've been away from my research. Oh, it feels like way too long, but for the better part of a year. And this event and having the ability to come and speak at the event is just fantastic because what it does is it reminds me of how important it is what we do and how important it is for the field and the area. So, I mean, mental health and IBD for me started some time ago over a coffee break with guys in the GI department and ladies in the GI department that I was working with. And some of my discussions, obviously being the psychologist around the table, were focused and biased on pain, on health, and on kind of management of chronic illness. And those things together really caught fire in some discussions, and here we are, 15 years later. So I'm going to share with you our slides. I'm going to share with you probably 3 or 4 research projects that I think are important that highlight kind of more recent developments in our understanding of depression, suicidality, which was mentioned earlier, and suicidal behavior. And more importantly, though, ways to kind of combat these types of issues that unfortunately many of our patients face. So that will be, kind of the journey I want to try to take you folks on tonight. And I'm excited to look at these presentations or these images of research in a variety of different ways. So let's say that's my preamble, and I'm kind of ready to go.
Hey,
Um,
Dr. Tripp.
yeah,
Yeah,
go
the
ahead.
English slides are up. I don't know if you can see them.
I can't see any slides. I'm just,
Um,
all I see is the French slides, and I
okay,
don't see any English
so
slides.
at the top of your screen, do you see CCC English that you can click?
I'm clicking it now, and there I am. Thank
Okay,
you.
perfect. Yes, so we can begin.
Yep. I think I was stuck on Lisa's, and I was like, oh, where am I
Yeah,
going here?
no worries.
Okay, so thank you. So we can go to the next slide, please. And one of the things that's really important, I think Arielle touched on this, is this codependence of factors inside of IBD. And when I'm going to talk to you tonight about mental health and depression in particular, I really need you to understand that the research out there highlights exactly what Arielle was talking about. There's biological factors, that are important in Crohn's and colitis, obviously, but there's also biopsychosocial factors that are, I would argue, just as important given certain situations in regards to patient outcomes, like quality of life or depression, or just sort of satisfaction with life in general. So I'm going to talk about a variety of these outcomes that are important. And when you think about it, as Arielle highlighted for us, and I think she did a great job, chronic stress leads to greater disease activity, which in pair influences your quality of life, which in tune grabs onto you and can result in a state that we call depression. And then again, you're in that vicious cycle. So the flow between your biology and your psychology is not different. I need you to understand that. We compartmentalize treatment, but the way patients experience this disease in particular, and many chronic illnesses, is it's not a biological thing only, and it's not a psychological thing only. It is a combination event. And I think that's really important for people to kind of hear as we start this. Next slide, please. So, yeah, and you can just click 1 or 2 here while I'm talking. There's psychosocial factors, and we talk about them. What are they? There's psychological and social-based factors and clinical determinants of Crohn's and colitis. And when we think about active IBD, flares, pain, which I've conducted several cool research projects on, and with our patient groups as well, which has been really fun to do because they just have such insight. So it's so exciting to work with the patients in our area in particular. But these kind of unpredictable symptoms is a hallmark of the diseases, the physical burden, the public nature of some of the symptoms, the embarrassment that sometimes comes with symptoms in public in particular, and how that can affect your mood. Next button, please. Yep. And then the unpredictability of disease, whether we're talking about Crohn's and colitis, or we're talking about fibromyalgia, or we're talking about interstitial cystitis, which I'll talk about later, or the urological disease in the bladder. The unpredictability of whatever disease you have to manage, and again, I could use diabetes as an example, is what really weighs patients down. Because we, as Arielle mentioned, like we are human beings, and human beings strive for control and predictability in our lives. And when that's taken away, it's hard to manage, and we have to flex and we have to adjust. And I'm going to talk about coping in a couple of slides, but let's say, it's not always as easy as we might think it would be, or how we hope it would be. Next slide, please. Yep. Keep going. A couple more clicks. Good, right there. So one of the things that's interesting to understand is that when you're talking about psychosocial factors, and Arielle mentioned this, and we're talking about, a current or a history of early stress, that can create a vulnerability to IBD flares and depression. I didn't, it's interesting how that lines up with Arielle's experience and that evidence that suggests that that's there, because there is some evidence to show this quite robustly now in Crohn's and colitis. And the thing about coping strategies, Arielle mentioned avoidance. Denial is another one, where you're basically going to be suppressing information or acting like it doesn't exist. And these are coping strategies that in the short term can be beneficial. Like, especially if you see something, or you see something terrible, or there is some really strong negative experience involved that you're involved with. Sometimes you need to deny that. You need to suppress that to get on with what needs to happen. But I always say it's akin to a funeral. When my father died, I remember I had to be the oldest son, and whatever that means. And I had to kind of, thought I had to, hold it together, and so on and so forth. So I just basically stuffed those emotions down, and and denied their existence, and had a tough face through the funeral. But I can remember just driving home, and all of a sudden, I don't even remember the song. It was just a song on the radio, and I had to pull over and cry for about a half hour. And it is this idea that those strategies, those coping strategies, can be useful in the right situation for a short period of time, but they don't do well over time. Even over a short, extended period of time, they may not serve you well. So self-management strategies, again, like not adhering to medication, poor diet, smoking, are all linked to depressive symptoms as well. So what you choose for coping strategies is important. And choose is a very interesting word. I'm going to come back to that. Other predictors that we're concerned about, well, being female alone with Crohn's disease means that you're going to have a rougher ride in terms of the disease. We can talk about that a little bit later. And education, presence of others with chronic conditions like hypertension, or other diseases that you may be experiencing, including interstitial cystitis, which has a high comorbidity. And again, it's a bladder-specific disease that you see in urology. They're all risks for depression. And one thing else that is a risk for depression is IBD-related surgeries. Not because the surgery creates depression, but that it can create behavioral difficulties, like we saw in Arielle's example there, that can lead to depression, which can lead to complications again. Again, a cycle, if you will, between how you're feeling and how you're feeling biologically. I say it 100 times a talk, you cannot separate those. Okay. We think about them in different compartments, but if you don't feel right, emotionally, one of the things that starts to happen is you don't sleep right. And we know that maybe that's part of the problem is you don't sleep right, you don't eat right, you don't take care of yourself, and then you say, screw it, I'm going to have a smoke, I'm going to have a beer, I'm going to have this, I'm going to do that. And that type of response, that behavior tips your biology over. And does that make you feel better when you try to cope like that? No, it does not make you feel better. So these are really important kind of ways to think about the connections between your body, your behavior, and the outcomes that you experience, and how that's a cycle. So I think when I talk about depression in IBD, I don't want to talk about depression as anything else except a landing spot where you get either because of biology, because of medication, because of how you're feeling, and or a combination of all of those things together. So when Arielle says we really have to pay attention to the individual, and she made it very clear that she expects that her individual journey can be different from yours. There are still aggregate pieces of her journey that are consistent and many other patients will experience. So I think that's an important thing that we have to look at the individual in front of us, but knowing that this research in aggregate gives us some indication of where to go and how to help most of the patients that are responding to these projects. So let's go on to the next slide, please. So at this point, I feel like I'm kind of already doing this, but it's kind of like a point where I'm going to say, well, what does this mean? Right? So depression, when we talk about depression in patients with IBD, we know it's cyclical. We know that it can produce more severe progression. It can also be a product of more severe progression in disease, and surgery and hospitalizations are part of this. And that vicious cycle, again, is part of what I want to emphasize today as we go through this, because mental health does not exist in a vacuum. Let's go to the next slide, please. One concept I want to introduce is something called catastrophizing. And, I want to first say that catastrophizing is not unique to anyone who has IBD. It's not unique to anyone who has diabetes. It's not unique to anyone who has any chronic illness, including chronic pain. But catastrophizing is a variable, a construct that we use in terms of talking about how people get to a place where what they see is a catastrophe, right? So it's a psychological process, it's an appraisal process, an evaluation of your world, and that leads to this catastrophe that you're telling yourself mentally. So it's not like we don't do it every day. I mean, I catastrophize. My wife catastrophizes. My son catastrophized the other day when he got his exam grade back, which I could see why when he told me the grade. But jokes aside, the idea is that, these types of experiences are normal. But when we're studying catastrophizing inside of, the various sort of health conditions that we're concerned about, we're talking about, trying to find an extreme. And if in finding people who are elevated in this catastrophic thinking, we start to map out treatment models. And that's really was the most important reason why we were looking at this variable so frequently in our IBD research. So just a couple of points here. Catastrophizing is a predictor of depressive symptoms over and over and over again. Catastrophizing is super important in depression and anxiety disorders. It's one of the main treatment targets, if I can use that term, in both anxiety and depression management. So one of the things about this thinking pattern, because it's like an anxious, worried kind of thinking pattern, and I'm going to talk more about its pieces later, that gets you caught up. And when you get caught up, you feel like you can't get out of it because this thinking is almost automatic. It is automatic. In fact, in cognitive behavioral therapy, we call it automatic cognition because it comes without awareness until that awareness is built through a therapeutic process. So it is connected to worse depression and worse development of anxiety as well. Patients who report higher catastrophizing than others, because not every patient with IBD reports highest level of catastrophizing. That's not true. We know with people that suffer from IBD that have lower scores of catastrophizing and other variables that they have a better quality of life, or they report a better quality of life and lower levels of depression. So we know it's a linchpin and we know it's an important variable. But I want you to think about catastrophizing as an anxious mindset. An anxious mindset. Some people don't like the word, I don't want to be told I'm having a catastrophe. But if that's the interpretation, then that's the interpretation. But I know a lot of people would prefer to hear it as an anxious mindset. And I think that works for me too. But I'm going to refer to it as catastrophizing tonight, but understand what it means is that this type of processing information, this type of thinking about your world exacerbates the negative impact of your chronic illness. That just makes it a little worse. And once it starts to get out of your control and you start to feel helpless, I think we can see some of the points that Arielle made so poignantly happen. So we're careful for this construct for a lot of reasons. Next slide or button. Let's see what pops up. Yes, and again, vicious cycle. Now I'm going to include catastrophizing into that vicious cycle. Next slide. So when I talk about catastrophizing, I want to give you a little bit of understanding about it because, it does have impact on IBD. It can turn usual symptoms like pain and bathroom urgency into overwhelming events, like I said, or catastrophes, depending on how much anxiety they hold for you. If you look at the diagram here on the screen, you'll see that pain catastrophizing has a couple of features in it. There's one called magnification and rumination. Those 2 points are really important because you can see those are how people are going to look at pain when they have pain. So pain catastrophizing is about catastrophizing about your pain and pain symptoms or the threat of pain or the thought of pain coming into your life at the moment. So you can see under magnification, you tend to worry or wonder if it's going to happen. And, that's kind of magnifying the threat value of it. Rumination is where you just want it to stop and you can't stop thinking about it. You get caught in that thinking trap. And that's hard. These two pieces, the front pieces, tend to happen early in disease states. And over time, as those start to get more ingrained, you start to feel the second part of this, or the third part, which is helplessness. And when you think about magnifying the threat of an event or a potential event, because it doesn't even have to be a real event, it can just be what you're worried about. And then you ruminate a lot about it, you keep thinking about it, and you can't go away and you can't get it out of your mind. And you feel like you can't do anything to remove that. How are you supposed to feel? Hopeless and helpless. And when we're thinking about pain in particular, a cardinal symptom in IBD presentation, as we heard earlier, you just see there, I worry all the time whether it's even going to end. It's awful. It overwhelms me. There's nothing I can do to reduce this. I feel I can't stand it anymore. I feel I can't go on. So when you talk about hopelessness and helplessness, this is what some of our conversations early in my IBD research career were about. And I want to go to the next slide now, please. So that takes me to the research. Let's talk about the research. So this is a paper that we just recently published with Dr. Gates, who practices in Ottawa now, Margaret, who's a medical student in Toronto, and Michael Back, who's a colleague of mine here in the gastro clinic at the KGH and Queen's University. So we wanted to look at quality of life, and we wanted to produce a new model. So what does this new model look like? Let's just talk about it for a second. So we know that pain is common in IBD. We know 50 to 70% of patients report it, and 30 to 50% report chronicity in their pain. We also know that wide body pain is related to more sensory and affective pain. We heard Arielle talk about pain being an emotional experience. And we published that paper in 2022. I'm really proud of that paper. It was really nice to put it together with the patient endorsement that we had for that. And then we looked at, we were looking at the wider literature thinking, well, what are we missing? So Justin Gates and I, we started to talk a little bit about how different types of coping could be involved with kind of withdrawing or surrendering to pain. So that's important. Can we go back, please? Yeah. And you'll go one more click, I think. Yeah, thank you. And just to end this slide here, I think older IBD research suggests that variables like pain, psychosocial factors, and quality of life can change over time. And this was Leslie Graf's work, who you may be familiar with. Leslie's a fantastic psychologist and IBD expert. And all of these considerations together motivated this research that we produced on quality of life and just recently published. So let's take a look at the picture, I think, that follows on the next slide. Yeah, so this is basically an analysis, like a statistical analysis, and it's called a serial multiple mediation, which in plain language just means if we look at it as a time course, look at pain on one side, and on time 3, we have health-related quality of life, which is approximately a year later. And then we have 2 measurements in between those 2 times when we assessed pain and when we looked at their health quality of life. And we measured catastrophizing, pain about pain, and we also measured a coping strategies called illness-focused coping. And you can see here guarding, resting, and asking for assistance. And not just asking for assistance once, but pretty heavy reliance on other people to do things for you. So we call those illness-focused coping strategies because in the long term, although asking for assistance is good, it can be associated with a bunch of negative outcomes if it's overwhelming, asking for assistance, et cetera. And guarding and resting and becoming sedentary is also not indicated in a lot of conditions, given appropriate settings. But what's interesting in this model is that the solid lines mean something here. So pain leads to higher pain catastrophizing. So higher pain leads to higher pain catastrophizing. Pain catastrophizing then predicts higher illness-focused coping. So when you catastrophize about your pain, it produces higher negative coping strategy use, which then goes down to predict a drop in health-related quality of life. So what's important about this longitudinal model is a couple of things. Go to the next slide. Yep, and you can put all the takeaways up. I think there's like 3 or 4, or maybe there's just 2 or 3. Thank you. The current results really tell us that we should be screening for IBD quality of life. We know that in terms of medical visits or peer review visits or any types of visits we have, it should be discussed, it should be talked about, but also risk factors that are associated between painful experiences, which is a symptom of disease, and its impact on our quality of life. And this is over time. This isn't just like in one snapshot, you had a bad week and this is what happens, which we would expect, but this is over time. So it is a little bit more compelling, a little bit more concerning to me. So our targets then, I'm always going to talk about targets are pain catastrophizing, and illness-focused coping. Those are going to be important because we're going to hear them come back again and again over the next little bit. So just in red, go quickly here. If the identification of pain occurs early, psychoeducational information about healthy adapted coping responses are important. So I think if I was to have a wish, and I'm going to have several wishes through this presentation, if I had a wish, there would be an education like to, here's your IBD, here's your diagnosis, these are the best ways to manage it. We can teach you the difference between this type of coping and that type of coping. And you take a course on how to manage this illness. That to me would be something I think would be super valuable. I'm sure not everyone would be interested in hearing about it at that point. But I think a course like that, if I can say that because I'm education biased, might have legs. It might be very useful for people trying to just navigate that beginning phase of their disease. Because as you probably are all aware, the actual lead up to diagnosis in IBD can be years. So you may be suffering for some time without, how can I say, skills management help for a long time. And if you're left on your own and you don't know how to manage it, it can be pretty terrible. So we want to avoid that. So study 1 really, I think, emphasizes that for me. Let's go on to the next slide, please. And this gets us to this next feature. I want to talk about a couple research projects we did here. And we did focus in on catastrophizing and suicidality at one point or another. So catastrophizing is important not only in depression, but suicidal thoughts and suicidal thinking. And in particular, helplessness is a key feature. We'll come back to that. And one of the things that's interesting is considering the high rate of suicidal thoughts and attempts among IBD patients. And I say high, I mean, it's elevated compared to many other groups of patients. I'm not saying it's 100%. I'm not saying it's 90% of patients, but I'm saying it's elevated. And in particular, a high risk group would be women and those with Crohn's disease. It's essential to include catastrophizing in a multidisciplinary care approach. And we know a little bit about catastrophizing already and why people get to that state, that kind of like anxious mindset. But let's go a little bit deeper here. Next slide. So this is a project we did some years ago, I think 2021, not too old. And it was a project we did in urology. And I'm using this project to set up the evidence to look a little bit deeper at IBD, which we will after we review this. And this is some of the people I work with, Chris Dorian, Curtis Nickel, again, a fabulous urologist, internationally renowned, who works out of Kingston as well. Next slide, please. So just hit a couple of knocks there and we'll see it'll populate.
Sorry, Dr. Tripp, can I just interrupt for 2 seconds?
Sure.
It's just that it seems in the chat that there are some issues with accessing slides. So we apologize. My team member who was supposed to be sharing the French slides, we're facing some technical difficulties. So we'll just stick to sharing the English slides. So, but we'll still have French audio. So for you to see the screen, right at the top of the window, your Zoom window, you should see a webinar or English CCC English screen. So if you click that screen, you'll see the slides, the English slides in full. And then also when we reshare the webinar at the end, we will ensure that the French audio matches up with the French slides. We will re-record it and put it up for everyone at the end of this webinar. I'm so sorry. Thank you, Dr. Tripp, for letting me share that.
Yeah, no worries. That's important. We want to make sure we have this presentation set up right.
Exactly. Thank you so much, everyone.
Okay, so let's click a couple of these buttons and see where we end up. Not there, that there. Sure, I gave you a short one. There's only 2 notches on this one. So, when we're thinking about urology, and this was the disease I was talking about, interstitial cystitis, the reason we did this research when we did it is because there was not a real good idea of the risk prevalence of suicide risk, not the act of suicide or attempts, but the risk. And the risk is like something that's a clinical indicator of action for me. It's like if I see a risk factor that's elevated, it means therapy, it means action. So this is why we try to do it this way. I want to show you another picture. Let's go to the next slide. I think it will show the picture. This is a picture that basically talks about risk. And as you can see here on the red bars, comparing the suicide risk measure that we had and the general population here, we can see that it was all like 39% of the group of patients that we had for this study were showing at risk for suicide. If we look at, and that's comparing against the general population, the blue bar were the people who are not at risk, which I'm glad to say is more than the people who are at risk, like I mentioned earlier. And the inpatient population risk, again, was just under 30%. So these are significantly worrisome risk rates. And this, I think, made us feel even more justified in kind of pursuing this line of research. Next slide, please. And here's I apologize for a stats slide, but this is basically going to tell us, this slide tells us what are the most significant predictors in regards to suicide risk. And I did it by pain group as well, because I was very interested in this. And the fallout of the scores are interesting. On your left, you'll see the different variables like exposure to suicide. So if a person was exposed to or had seen or heard or had a family member who was involved with an act of suicide, you saw that that was a risk factor across everybody who had low, moderate, or severe pain in this group. Insomnia was a predictor as well in the low pain group. And as we come down, you can see catastrophizing, they're underlined in red, was a predictor in the high pain group. So we see the catastrophizing, and it was the helplessness scale as well that I mentioned earlier, that you feel you can't do anything about it. It's terrible. It's never going to get any better. That is kind of a predictor of suicidality in the severe pain group. So hopelessness under that is the next one down under catastrophizing. And you can see that variable, which is very interesting. It's highly correlated or associated with catastrophizing, but in this sample, it was way more predictive. It predicted across all the different pain conditions in terms of it being low, moderate, or high, or severe, I should say. And that was really an eye-opener because we weren't expecting to see that. One other thing that was really kind of different was in this analysis, you can see there's perceived burden down there, thwarted belongingness, which is a mouthful to say, depression, psychache, all these different variables were used. They are all drawn from the suicidality literature. And none of these variables were used in urology, and none of them were used in gastro before we did these 2 projects. So you can see here the takeaways, and we'll get to the next slide. And the takeaways are that the suicide risk prevalence is about 38%. That is elevated, and we need to do something about it. Targets for intervention are a person's exposure to suicide, so their history of trauma, psychache, which was another variable that we talk a little bit about, but I think hopelessness and the perception of burdensomeness were important, more important here. And also catastrophizing, which I must have typoed out, but catastrophizing was also important. And again, if we think, we can just go to the next slide, but if we think about how these things operate, when we were sitting around the gastro clinic and we are talking about, stress and depression and et cetera, no one was talking about suicidality at the time we started this project. So we said, okay, we need to model symptoms of suicide risk, just like it says here, and IBD, and we need to model how it unfolds. Very, very important for us. So one of my star PhD students who's now graduated and working in Toronto, Tina Mihalovich, she and I and Jill Jacobson at Queen's put this project together. And let's have a look at what we found. Next slide. So there's a couple of points here. They're very similar to the slide in urology, except the link between IBD and suicidal behavior is limited in IBD for sure, just like it was in urology. And this idea, again, about suicidal behavior concerning IBD, like there's little been done on examining suicide risk, so ideation and attempts. So basically, we tried to identify the prevalence estimates for IBD in relation to suicidality, but also show how biomedical, psychosocial, and theory-driven predictors could help us understand who's at most risk. Next slide. You'll tell that on the next slide comes up, I'm a sucker for pictures. This is the best way to describe a very complicated statistical analysis. It's something using structural equation modeling, we call it in the game. But one of the things that's important is just if you look in the upper right-hand frame of the picture here or the slide, you'll see that the incidence or the prevalence, sorry, is almost 41% of the sample indicated clinically significant suicide risk compared to the adult general population. Very similar to what we saw in the urology group, and again, which also has a high prevalence of depression. I did mention earlier, but it's worth mentioning again, the crossover between IBD and that other disease we were studying in urology, interstitial cystitis, the comorbidity is about 38% in patients. So that's kind of made a natural link to this study, those two studies coming across. So in this study here, we had a different layout of symptoms. In particular, we used a variable called psychache. You can see that there instead of catastrophizing, and we were more focused in on the kind of the hopelessness feature and how that might be modeled, because that side of the diagram really is from the suicide literature and the suicidality literature more than sort of the depression literature. So we went back here and we started to look at if you go left or right, it's kind of unfolds that way. And every one of these lines that's here shows a connection and influence between the variables. So IBD symptoms are obviously going to be illustrative and connected to higher average body pain. Interestingly enough, we see that IBD symptoms as well are a strong predictor of shame in our patients. And that was a new variable that we wanted to examine as well. And in combination, you can see those three variables that I just mentioned are all connected again to elevation in depressive symptoms. So what's important about that first part of the model is it sets us up to understand that depression has always been a risk factor for suicide, or suicide risk factor, I should say. But what we haven't modeled is what variables in between are important for us to think about. Because if we don't know what kind of mediates that relationship or sits in the middle of it, we don't have a way to intervene. So this is about, I call this one of my intervention maps, because when I look at this, I see that if we drive down hopelessness and we attack the burden that someone is to someone else, PB, that perceived burden that you are to other people. And we look at this other variable named psychache, which is kind of like just an emotional pain. If we think about targeting those variables in a therapeutic approach, we can disarm the risk for suicide or the suicidality risk. And that can be very, very poignant because everyone's going to show up with a little bit of a different flavor, but these patterns are aggregate. So there are things that your patients, when patients filled out all these measures for us in these reports, this is their voice on aggregate. So it's like an average response across all the patients. So again, I'm going to hit a couple of these on the takeaway slide, please. Next. And a couple of bullets. So we know something about IBD that we did not know before we conducted this study, and that was that biomedical variables like symptoms, average pain, were associated with psychological variables like shame, which we hadn't looked at before, depressive symptoms, and hopelessness, and that they were related to theory-driven factors, psychic, and the burden that you think you are to other people, which, again, we're going to talk about social support later on, and social support is the recommendation. It is the medicine for that perception of burdensomeness. And we know that all of those variables combine. It's a complicated story, but those variables combine to promote greater suicide risk. So one of the things that I don't need to talk about the bottom slide because it's an omission, but that's really the big takeaway from that. So go to the next slide, please. Over the course of a month, this is very important. About 40% of the individuals in that sample of IBD patients were at clinical risk for suicide compared to the general population. So the targets are depression, hopelessness, mental pain, and that perception that you're hurting others by being around, that you're a burden to them. Without knowing, you perceive yourself to be a burden, and that can be dangerous. So regardless of the sequence of the risk factors, IBD management, in my opinion, should adopt an approach that integrates management of disease activity, including pain, super important, maximize our medications, do our best to get ourselves biologically fit as best we can, and concurrently, same time, work on the psychological well-being. I think that's a very important, over the last 2 or 3 slides, I think it's become very important focus for me in my research. Next slide, please. So, again, what does this mean? Well, it means that those factors I just mentioned, they're significant in abdominal disease. So, and abdominal pain diseases, I should say. So we need to know that in terms of these key factors, we know they make things worse. So how do we make it better? Next slide. And this is where I talk about clinical answers. So let's see what I got here. So we talked about catastrophizing before. Again, if we think about it as a two-stage process where magnification and rumination, how you get trapped, and I call those thinking traps. When you get trapped in that thinking and you can't get out of it because you're very anxious and if you isolate yourself, and you allow that thinking to happen, you just create more distress and more of a circle. That circle leads to helplessness. And it's the helplessness that seems to be the big factor in pushing people towards worse outcomes in disease and in deeper depression. Next slide. So this worksheet, sorry, not workshop, but I use this worksheet a lot in workshops, it's called a decatastrophizing worksheet. And the print might be small, I apologize, but basically there's 3 sections in this worksheet. And this is the basics of helping somebody walk into like a catastrophic interpretation or a catastrophic experience for them that makes them really anxious and really worried and feeling helpless, and walk them through it. And it's really, you can do this. I had a student, maybe a couple of weeks ago now, defend a master's thesis in the department, and she was really, really anxious. And I said, okay, we're talking about catastrophizing, and we're talking about lupus at the time, another disease that she wanted to study, so arthritis. And this poor woman was so stressed. They said, why don't we do what we're telling patients they need to do? I said, you need to do this sheet. I said, go away and do it and come back and we'll look at it. Because she knew about it, but she'd never actually done one. And when she did it, she came back and it was great. She's like, I get it. Yes, it works. I feel better. Okay, now let's get on with things. So what is decatastrophizing? It is and this is a free online tool, but basically in part of the first step of this, you basically want to say, what is the catastrophe that I'm worried about? And, basically you can clarify what I am worried will happen, what am I predicting will happen, and then, change these what ifs into a different type of language. But more or less, in the first part of this, I want you to tell me what the catastrophe is. I will never be loved by anybody. People think I'm ugly in terms of social dynamics. My future in terms of my education is over. I hear so many of these things because I've had patients that are also students at Queen's that have come and joined our lab at various times, suffering from Crohn's and colitis, and their insights have been valuable. So when you have this catastrophe in your mind, like I'm unlovable, for example, let's say that's it, and you see it unfolding, I'll never get married, I'll never have children, I'll never be able to do what I want, there's 1,000 things that run through someone's head when they're in that state. I get them to rate it. Rate how awful you believe this catastrophe will be, from predicting if it happened, how bad would it be, 0 to 100. And then we get to go down through the worksheet of it, the meat of it, as I call it. So then we ask them these questions. We understand where you're sitting. How likely is this event to happen? That's the first question. You can see there's a series of small questions for that. How awful would this be if it did happen? Which is something we often avoid. We always think, oh God, don't ever say anything to anybody about that, because if you get them thinking about stuff like that, it just could be horrible. But you have to ask the question, how awful would it be if it did happen? How awful would it be if you failed that exam? How awful would it be if one of your friends rejected you? How awful would it be if you failed in another attempt to kind of like be employed? How awful would it be if you admitted to somebody that you had Crohn's disease? These things are very important questions because people think it's the worst thing in the world. But as you start to go through these and test reality, sometimes it's not so bad. And that conversation's important. And then again, just supposing the worst did happen, how would you cope? This is so important because people don't get pushed on coping. They don't get pushed and they don't discuss it. Like I think Arielle gave a great example of how she felt kind of trapped in some of her coping, right? And so this again is these 3 super important questions open up dialogue. And you can spend minutes, you could spend hours on any one of these. But as you work through these, you get to a place where you start to reconcile reality from the stressful, catastrophic interpretation that you may have been entertaining, right? And I say may because there can be some truth in those situations, but often there is more mistruth and misinformation that you're feeding yourself. And I always say it's like self 1 versus self 2. In that argument, sometimes self 1 is saying things to self 2 that aren't actually true, but they sure feel like they're true. And that kind of debate about the reality and kind of what you can do about it is a really important step. And that is decatastrophizing. So at the end of this sheet, you can just see where you have to re-rate some of this, but you also have to talk to yourself about, well, what could you say to yourself? Well, it's not that likely to happen, or it wouldn't be that awful it happened. I'd be embarrassed, but it wouldn't be the end of the world. Or, just supposing it did happen, I would manage it. I don't want to have to manage it, but I'm pretty sure, given my history, I would come through. So those types of discussions and thoughts are key to taking down the heat on catastrophizing. And when you do that, people start to have benefits for sure. Next slide. And that was a piece, sorry, of the big slide. You can see that I tried to zoom it in, but then I had missed some. So I just said, well, delete that because the bottom wasn't on there. So it didn't make sense. But you can see the questions are a little bit better that way. Perhaps when you get a PDF version, you can just zoom in and you can see them. That would be the best way to kind of look at them. Apologies for that. So here's something else. Like I'm about to wrap up and say, okay, so this is good and this is what I mean and this is my message and I hope you heard it. But one of the things that just recently happened, we just published a brand new paper just very recently, and it ties nicely into this discussion because we were trying to look at, and there's lots of Crohn's and colitis funded research out there. This is a good example of it. Trying to look at whether peer support would provide benefit and how it would provide benefit to adolescents with inflammatory bowel disease. And it's a web-based peer support program. Let's go to the next slide. I don't have time to present it all, so I just wanted to put this little paragraph in here. there were no significant quantitative results, which means some of the questionnaires that the kids filled out didn't show significant differences, like kind of pre and post, and kind of like the changes we were hoping to see, because the numbers were close, but they weren't statistically significant. But the qualitative data that show that peer support for adolescents in IBD improves IBD care by fostering a sense of belonging with peers who share similar lived experiences. Now, think back. Remember that thing I called perceived burdensomeness in suicidality? If you feel you don't belong, you are a burden to others. If you feel you belong and you can share experiences, you're not burdening anybody. You're part of a larger conversation that can decatastrophize you in conversations with other people from lived experience, but also from maybe some therapy they took or a book they read or another resource that's on. There's a mental health resource on the CCC website that's also really quite good. So when I think about this latest brand new research that we just published, I think again, it's more evidence to suggest that the feeling of belonging, decatastrophizing, watching depression, very important to intervene on all of these factors. No more is it appropriate for us to walk around with our head in the sand about these psychological factors. You need to ask for them, you need to demand them, and we need to provide more. So I think there's a push on both sides of us to try to get this into a better place for patients. Next slide, please. So I'm going to stop there because I think these slides are going to be talked about by the group here. But basically, if you think about the peer support that we talked about, or maybe I'll just talk about them. That's fine. Crohn's and Colitis Canada does offer, and if you scan that fancy little diagram to your right when you get a chance, there's a whole bunch of different things like Ask the Expert events, Crohn's and Colitis Connect, which is a platform for patients only. And then peer connect events, enclosed small group with peers, and IBD Help Center. These are really important, features that can be helpful for you. I think there's another slide that talks about some of this stuff as well. Yes, the online IBD Knowledge Hub. Again, you can scan the codes and you can access them, or you can go to these websites for different. I mentioned mental health strategies. I think that's pretty decent. I've been there, I've seen it. And also for pain management, there's a nice little section there as well on managing pain, which we know is a cardinal symptom. So thank you very much. And thank you, everybody at CCC, for allowing me the time. Most importantly, thank you, Arielle, for sharing. And I'm happy to take questions. Thank you.
Thank you so much, Dr. Tripp, for sharing your research with us. We really appreciate the time you've taken to help us understand, the different research variables that are involved and how that ties in with lived experience. So now I'll be launching the post poll. Please, that's going to be up in 2 seconds. Let's close this. Just give me a second. I can see this. Polls. Back. Okay, launch. Okay, so it's launched. And then we'll just take a quick survey on how everyone feels after webinar. It's going up, Dr. Tripp. I'll share the results.
That's a good thing.
Yeah. So it just shows that this information was extremely helpful and good. Okay, I'll go a few more seconds. About 3/4 of individuals have responded. Okay, so I'll share the results. So as you can see, before we were around 5, and then now you can see that we're actually more towards the 8, 9, 10. So 7, 8, 9, 10. So that's a really good indicator. So thank you for everyone for taking part, and we're happy to see that this information was extremely helpful to our audience here today. Okay, so next we'll move on into the Q&A portion of today. I just want to share that if you have any questions, and we've been getting some questions throughout the webinar, so Dr. Tripp, After we go through the questions on the slide deck, we'll go over the questions that came in. I also wanted to share that we cannot answer questions about specific medical situations. So please keep that in mind, because your own situation is unique to your own, biological and social and environmental factors, and you should rely on your designated healthcare provider for insight.
Yeah, I'm just looking at the Q&A and just quickly,
Yeah,
because
of
I
course.
see some questions that I would like to
Of
kind of
course,
just talk
sure.
about. We won't have time to do all the questions tonight. I apologize for that. But I will also say, if you have a question for me that you want me to answer and we don't get to it tonight and I don't get a hold of it some other way, just email me, Google me and look me up. You can get me at Queens. I just want to say quickly that there's one in here that's important. What if the thing you fear is the truth, the reality you live in? The number one thing about that is, and I mentioned this, is that catastrophizing is not always about like some kind of fantasy in your head. There can be truth components to it. And this idea of helplessness and hopelessness is always about the weight of some of that truth and what I call, and this going to sound bad, but follow me on this, illogical thinking about logical situations. Like logically, you know that things are bad and they are bad, but you make illogical connections to outcomes because you're so far into it that you can't see out of it. And this is some of the things that happens often. This happens to me when I get all upset about life sometimes, and I have to get pulled out of it myself. But it's very common for patients with chronic illness that their disease just beats them down a little bit and it's harder to see coping options. Arielle mentioned that earlier, so I think we have some support on that. And I think the thing is, don't give up, don't lose hope. Talking, talking, and more talking. Even if it feels like you think talking won't be any good, won't be helpful, just trust me, please talk about it. Talk about it with someone you care about, someone who cares about you, and go to these peer support groups. You'd be surprised how much value you get out of hearing someone who's been in your shoes talk about how they've managed to kind of survive and thrive. But it is not easy. But the trick is hanging in there and talking, 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 talking. It's super important. So I just want to make that was one thing I noticed in the questions. I'm going to give control back to you, but I just wanted to say that I thought that was an important question. So I thought that I would try to get that answered before we moved on. So go ahead.
Yeah, of course. Also, there was another, I think, important question that came in, and I
Mm-hmm.
think it might be important to clarify before we move forward. So
Sure.
here's the question. Can you please reiterate what the definition of catastrophizing is? The dictionary states it's viewing or presenting a situation as considerably worse than it is.
Mm-hmm.
This makes the person who asked the question feel deflated, since they know that they're not making the situation worse than it is. So if you could just clarify, the
Yeah.
definition of catastrophizing, because I can see colloquially how
Sure. And this is why I mentioned earlier, call it an anxious mindset. I mean, you can change the language around. You can call it
yeah.
whatever you like. I mean, we wrote a paper in 2024, me and Dr. Sullivan from McGill, and Mick, as I call him, he was my supervisor at Dalhousie. Oh, well, I don't know, 30 years ago, a long time ago, and he started this bandwagon and research program on pain and catastrophizing thinking, how it's related. Don't think of catastrophizing as anything new. This construct has been around for decades and decades. Like the basic first treatments of depression were based on catastrophic interpretations of events. So in other words, how do you get to that place of catastrophizing? And I mentioned in that model I showed, and if we could bring up that green picture of the catastrophizing parts again, I know it's on there somewhere. That model that we showed in the presentation is really important to kind of understand because catastrophizing is a thinking process, right? And as I said earlier, I want to point this out again. I catastrophize. Um, Everyone I know catastrophizes. My wife, who is also a psychologist, catastrophizes. It is a universal experience. Call it anxious mindset. Everyone gets anxious, right? We don't debate that. But catastrophizing carries a weight because it's been used as defense, we would argue in our paper about about the catastrophizing construct, uh, it's been used against patients, where if someone didn't understand that process and didn't see it, how it could be broken down into different thinking and how it could be intervened upon, they would start to saying, to patients, it's in your head. It's in your head. It's all in your head, right? And that got terms like, oh, you're catastrophizing. That's what drove me nuts when all of a sudden catastrophizing became more and more a prominent variable, which it had always been in depression research, right? And no one panicked about it then. But when it became health research, people thought, oh, well, it's not fair. I really am experiencing these things this way. Well, yes, you might be, but you may also not be. And that's the trick of these automatic thinking programs, that we start in on this anxious thinking, that we get elevated and we start to see almost what we think is the only reality. The truth of that is that when you start to take it apart, and it is a slow process, right? When you start to look at your coping, when you start to think about, would I really not be able to manage that? When you ask those hard questions, which you, by the way, you never ask when you're starting to elevate in that catastrophic thinking. You don't ask those questions. That's why you elevate in it. That's why they become automatic, because you don't challenge them. So it's that challenging that is difficult. But the problem with that construct isn't that it's a great therapeutic construct, that it has a theory on how you can prevent it and work with it. But what it does have is this problematic issue of patients feel they're blamed because some people have said, you're catastrophizing, it's in your head. That's the wrong way to think about the construct. Shame on them for saying that. But we have work to do in fighting that, but it's a thinking pattern. That's a bit of my long-winded response. I apologize.
No, of course. Thank you for clarifying the concept. It's
Thank
concept
you.
of catastrophizing. Yeah.
It's
Okay.
complicated, but it's
Yeah.
not at the same time.
Yeah, I think there is sometimes when certain medical terms or research related terms get moved into the colloquial space, as you see, it gets misconstrued. So it's good to clarify.
But I
Okay.
think it's important
Mhm.
to attack it because, like,
Yes.
why do we have it? Right?
Mm,
Like the process, as I tried to show in the research, is super valuable
yeah.
because when we understand the type of thinking pieces that people fall into traps on, we can intervene. But if we use it to blame people, that's just completely inappropriate and not what we want to do. So it's great to have this discussion. Thank you.
Yeah. Okay. So we'll get into the questions. So these were questions that were sent in during the registration. So
Okay.
the first one is, could you describe the link between the vagus nerve and gut pain and recommend accessible research for non-academics?
That's a great question. Um, the short answer is no. I can't get into a detailed explanation of that. But in terms of resources that would be useful to understanding the access between how we feel physically and how that leaves us psychologically, and how psychological factors are involved with that stress reactivity, there's so much out there. I would suggest a simple web search. I do it all the time, a Google search or whatever platform you like to use, and just kind of drill down. There are also some good books, self-help books that talk about stress and the
Mhm.
biological association and factors in stress responses. Those can also be useful. But I don't have a particular resource, unfortunately, that I would say this is the easiest or the best way to do it. But I would say shop around. Ask other people at CCC. Someone always has a favorite book. I have like a ton of technical books and I have a ton of textbooks, but I don't think I have an accessible everyday version. But I know they exist. I've seen them in bookstores, but I think that would be the best place to start. I would think that's what I would do.
Awesome. And yeah, if you have any questions, always feel free to email ccc@learn@crohnsandcolitis.ca. We can definitely connect you with resources.
Yeah.
Okay. The next question is, what are the potential effects on the stability of inflammatory bowel disease?
On the stability. What effects? What do you mean potential effects? I don't
I guess
understand the
I
question.
think they mean like the mental health symptom
Oh,
on the
okay. Okay.
stability of inflammatory bowel disease.
Yeah, I'm going to ask Arielle to chime in on this one as well. but my initial response, oh, actually, why don't we let Arielle see if she wants to kind of chime in on that, and then what
Of
I'll do is
course.
I'll follow up with her. So Arielle, you go ahead.
Yeah, sure. Um, I do think whenever you are talking about mental health and trying to measure like stability and trying to get like a specific number or percentage, it is hard because everyone is so different. So
Hmm.
for one person, they could have more stable mental health.
Mm-hmm.
Um, like Dr. Tripp has said, like two people could go through a similar experience, and for one person, it could be so overwhelming, and for the other person, they could manage quite well. So I think that is hard to measure specifically, but I think if you look at your journey, and I know for me, like I always compare myself now to where I was, and I find that's a more helpful measure because we can't predict stability. And like even where I am now, I don't know what's going to happen in the future with my IBD.
Mm-hmm.
So what I can do is like focus on managing my mental health and like learning how to cope and learning how to be resilient. So when those challenges do come, because IBD is chronic, there's going to be flare ups again. I'm going to be rehospitalized and I'm going to, maybe have to change medications again, or maybe I'll have more surgeries. Who knows? Like these things are going to happen. So how can I proactively like be prepared and like increase my tolerance? And that's not to say that like controlling the stress and like all these things are going to be perfect. It is going to be hard, but I think it's how you're able to manage it can really make the difference between something being like so catastrophic and something being like, okay, this sucks. I don't want to be in here, but this is what we're dealing with, and this is how I'm going to get through it.
Yeah.
I love that. I love how you said that. And this is something that I hear so often. And we heard this in some of the earlier questions as well. And that was this idea of like, I'm in a terrible place. No, I don't want anyone to say that that's not true. I don't want anyone to think that I would be challenging that perspective. It is a terrible place. Chronic illness is a terrible place, and it can be horrible on certain days. It can be extremely horrible. But on other days, it can be manageable. And on other days yet, it can be also almost feeling like a little absent, right? And that's what you got to hang in for. Like that. So stability in chronic illness, especially when there's uncertainty in the disease, as Arielle just described, it is a day-to-day battle. And if you try to fight that battle by yourself, and there is a point that you do fight these things by yourself, there's no question. But I think if you have, I often hear people talking about building out their team. And that's part of it because the stability of this disease is, if you're, like we said, if you're going to transfer into a state of depression, your disease is going to be highly reactive. And along that process, if you have, for no fault of your own, highly active disease, you might be entering into a state of depression. So is that kind of flow between makes it so unpredictable that I think stability is a really good, how can I say, I think a really good word to use because it's the stability in how you keep coming back is the most important thing if we use a word called stability.
Um, so very quickly, someone pointed out in the chat that the question actually was, what are the potential effects of SSRIs on the stability?
Oh, I didn't hear SSRIs.
Oh,
Okay.
no, no, that's my fault. Don't worry.
Yeah,
Sorry.
no worries. I didn't hear that. And I thought that's why the question went in a different direction. But I
Yeah.
will talk quickly about SSRIs. And then I'm not asking Arielle if she's using SSRIs or has, but I'm going to talk a little bit about this. So I think the effect of SSRIs and SNRIs as well are important on IBD in terms of stability. I think that's what the question was.
Yeah.
Because it's complex. And it appears to be, from my read of it, working with psychiatry, because I'm not a prescriber of these medications, but working alongside psychiatry, you'll hear them talk about this be kind of biphasic, is an interesting term. And biphasic, kind of means that these SSRIs can offer some improvement in disease activity in some cases, but long-term use, continuous use, could be problematic. So when we talk about the treatment of depression, SSRIs are indicated. There's lots of good evidence to suggest with psychotherapy, talking therapies, that you're going to have benefit. But there is also some literature that I'm aware of that is kind of negative in terms of some of the outcomes with, I guess, increased flares and sometimes, if I remember correctly, corticosteroid dependency or something along that line. So I think it's a bit biphasic. So it could be useful at a certain stage, but should it be there continuously over a long periods of time? I think there's less evidence to suggest that might be the way you want to go.
Thank you. Another really important question came in that I think could be really impactful to our audience, which is, so, and I think this could be answered by both Dr. Tripp and Arielle. Could you please provide concrete tips on how to get out of a feeling of hopelessness and negative thoughts and that vicious cycle as you were talking about, Dr. Tripp? So something, the concrete tips for folks.
Yeah, we'll let Arielle go first.
Yeah, this is a great question. Something I definitely struggled with. And I would just say that I think getting support is huge because we cannot think ourselves out of the bad thoughts, and we cannot like stop the rumination or like think ourselves out of rumination, because that just turns into self-blame and like, you shouldn't think this is bad, and that just fuels the cycle of shame and anger and turning things internally, which then will produce stress, which then can cause inflammation or can just make you feel crappy. So it's really important to cut that pattern. And like I mentioned, some tips that work for me, like journaling, talking to friends, gaining support, just saying it out loud, like, I am in so much pain today and I'm not happy about it. Like, there is like physical relief that will come off your body when you let things go, whether it's verbally or putting things on paper. And also like therapy, I would just say again and again, I think I'm in training to be a therapist, so I'm a little biased in this, but I truly think every person with IBD needs to have therapy, because we need to change how we are treating this illness. We need to start treating this from a quality of life lens. And right now we're only treating this from symptom focused, and we're missing that psychosocial piece that really connects everything. And feeling hopeless, having negative thoughts, there are strategies available and skills you can learn that you can manage that. And sometimes some of those things go away too. Like if you're like I was, where I was just stuck in this cycle and literally thought that's how my life was. It's not to say I never have negative thoughts, but I now recognize them so much. And I can say, whoa, like this isn't actually from me. This thought is actually not a value I hold. So I'm not going to spend time thinking on it.
Sorry, I was just going to add, I think that brilliant, good description. You described my research exactly. It's like I hired you to say that. I appreciate it. I think one of the things that I could add is that, you have people in your life that can also provide support. And if you're a caregiver and you're a provider of that support, I think you can look at understanding that IBD flares and or mental health struggles, they can be treated through compassionate listening. And this concept of just having a listen when you're a caregiver is super hard to do because you yourself might be in panic mode. You yourself might be, I need to save my little girl and I need to go rescue her from this terrible situation. So you're really panicking out. But if you get into that listening cycle where you're just giving it that ear, and you're just allowing the person the space to kind of talk about where they're at, what they're struggling with, offer some practical help, educate yourself about the condition, and encouraging professional help like Arielle just did to everybody here. She's encouraging you to find someone who's professional, who's trained, use them and peer support and this other person. It's not one thing that usually makes the difference. It's the combination of attempts of going over these possible ways to get better that turn a light bulb on. And I think that would be, it's a long-winded kind of approach, but I
Yeah.
think our two things dovetailed nicely there. So I just want to interrupt. I apologize for that.
Mhm.
And I also wanted to add, if if you're feeling like you don't have a community, as I mentioned throughout this talk, CCC really prioritizes setting up this community for individuals affected by IBD, either as someone with
Yes.
IBD or a caregiver. So please reach out. They're virtual, they're accessible. So please reach out, and we will love for all of you to be part of our community and feel that support that Dr. Tripp was talking about, that even his research showed, which was that feeling of belonging and reducing perceived burdenism.
Yeah,
Um,
100%.
okay, so we are at 8:35. Um, I was thinking, Dr. Tripp, are you okay going for another 5 minutes and then
Sure.
we wrap up? And Arielle,
Arielle's good. I'm good.
okay,
I'm good.
thank you.
I'm good.
Yeah, we're getting like, I mean, obviously this is a very a topic that doesn't have much exposure, the mental managing your mental health in
Yeah.
IBDs. So there's a
Yeah.
lot of questions that are coming in, and it would just be great if we could.
Oh, we can stick on for another 5 minutes. Let's try to tackle some.
Okay. So another question that came in, which was, what about stress and pain from extraintestinal manifestations that are not fully discussed and taught how to deal with?
Mm.
Um, when can be dealt with, as IBD can be in remission, but life isn't great because of these extraintestinal manifestations or EIMs. And if you have a rare one in your lungs, so I guess they're asking for support when maybe you are in remission, which could be contradictory, but you still are
Yes.
experiencing pains from extraintestinal manifestations.
Yeah. Arielle, you want to go first, or do you want me to try
Uh,
this?
this is a great question. And I would just want to start by saying, I think we need to be careful how we use the word remission, because this is
Mm,
often said as can be felt as your remission, you don't need support, you're good, you're not in pain. And this is so far from the truth. Um, I'm often in remission, but I deal with chronic pain daily. So I just want to validate anyone who has gone through that and have been told they're in remission, even though they may be having symptoms, because it's not a vacuum, how the body works. So, and in terms of extraintestinal symptoms, they are more common than we realize. And I think, personally, I would do my own research on how to support them and also figuring out for yourself. Because I think that's the thing is with pain and discomfort, there's so many different things you could try. And that's why there isn't a perfect manual we could just give someone with IBD, because sometimes medication helps and sometimes it's heating packs or physiotherapy or different things. I know I was diagnosed with arthritis, which is one of my extraintestinal manifestations. And so I will experience joint pain and swelling, and that's hard and has nothing to do whether I'm sick or in remission. It just is there, and that's hard. So for me, I use a pain cream for that, and I rest. And resting can sometimes be frustrating, but it's what my body needs.
mm,
And I need that way more than the average person. So I think I would just say it is a very unique thing, finding out what works for you.
mm.
Advocate to get a doctor or a specialist, or if you're still not getting your needs met, or you feel like something is missing, keep pushing. Your team should be working for what you need. And if you feel like something is wrong, just always trust your gut, is what I would say.
I love that. Trust your gut. I love that because sometimes you don't want to trust your gut because you think your gut doesn't like you very much, but that's a nice comeback. I think I love the idea of remission. And one of the things that's interesting is I loved how you addressed that, Arielle, because my thought immediately when I heard the term remission is I see patient after patient that says, I'm in disease remission, but I still have my pain.
Mm.
And it's like, oh, okay. And I remember my early contact with Crohn's patients. I was because I'd known two youngsters that grew up with Crohn's that were friends of my children, and they tried to be engaged in sports and they were athletes, but they would have to take time away and stuff like that because they had disease activity. I'm in remission. And one of the kids said, I always hurt. And this was like a kid, like you said, a 13, 14-year-old. I always hurt. It's just kind of, and I've never left that. It's always been in my head. And if you think about other diseases, like IBD doesn't stand alone in that. Like remission in interstitial cystitis, the primary symptom of pain is still there. Like it might be muted in remission. It might be, there's times in that ebb and flow of the disease state that, it's a bit muted, but it's not gone. And that's so the idea of what truly is remission can be very different from patient to patient. So I think that Arielle nailed that on the head. But I just wanted to add that in my experience that remission is mysterious. And that's what makes the disease so unpredictable. Even when you think you're clear and you hear remission, you may run into some difficulties that are challenging. So I think that's the idea I would leave you with on that one. Thank you.
Okay. I think we can wrap up there. We're at 8:30.
Well, there was one more. Hold on. There was one more I liked.
Oh, yeah,
And
of course.
there was a question about depression and resources and kind of where you could look and what's a good article. And there is a great article that's actually was Crohn's and Colitis Foundation supported. And I was mentioning this article earlier off camera, and I love it. I think it's a fantastic article. If you want to think about depression, in particular, focused on women, there's a great review paper out, and it's by Shoma Bomena and her group, and it was published in 2022 in Inflammatory Bowel Disease, volume 29, pages 1957 to 1970. And it's called, the article is Depression in Women with Inflammatory Bowel Disease, a Multifaceted Approach for a Multidimensional Problem. So that's Bomena, Goldberg, Amini, and Alashia. And it is a fantastic article. I would recommend it. It's actually quite readable because it's a review article and it does hit a lot of really cool research. It's a bit thick, but you can take your time with it, and I think it would be valuable to read. So I wanted to throw that in there. Thank you.
Awesome. Thank you so much, Dr. Tripp. And yes, we will also try to see if we can find the paper and if it's open access and share it with everyone.
It is. And you could,
Okay, perfect.
I could send it to you if you want. I have it.
That would be great. Thank you. So that wraps up our Q&A portion. So Dr. Tripp and Arielle, thank you so much. Usually the lived experience partner, doesn't tend to be as involved in the Q&A, but I loved it. I think it actually really adds an excellent perspective to the answers, which is, closely ties in, like you got all the intention of the questions right away because you are someone with lived experience and you were able to share, I think in a way that was extremely.
Well, see, this is part of Arielle's journey. Like,
Yeah.
This is who she's becoming. Like this is where she sits now, compared to where she started this, and it's been a hell of a career. But when you think about where you are today, I'm proud to have shared the stage with you today. I really do appreciate meeting you. And it's just such a positive spin on something that can be real tough. And it has been real tough. And I appreciate you for that. So thank you again. I appreciate it.
Thank you so much.
I echo those thoughts. It's amazing. So quickly wrapping up, thank you again to Dr. Tripp and Arielle for taking the time and staying a little bit over. We really appreciate it. Very quickly, as I mentioned throughout this webinar, if you have any questions or need any support or help, please reach out at learn@crohnsandcolitis.ca. It's the first step. And you might even be in a peer support event with Arielle at some point, so you might get to see her again. I also want to share that this webinar the Gutsy Learning Series is supported by grants from Pfizer, Johnson & Johnson, AbbVie, Takeda, and Merck. You'll also be receiving a quick post-webinar survey just asking you about how we can improve and also feedback. And lastly, please follow us on any of our socials. We are always posting and sharing resources. For instance, we recently released a IBD guidebook. So that's for individuals that are newly diagnosed. And it's a great way to have insight into what CCC is up to. And that wraps it up for tonight. Again, thank you, everyone. We will be sharing an e-blast with the video recordings within a week of the webinar, and it will also be posted on our website and YouTube, so you can catch all of this there again if you missed something and you want to take a look again. Have a wonderful night, and we'll see you at the next webinar December 10th on new and emerging therapies in IBD. Good night, everyone.